Okay, Reza, do you want to go ahead?
Awesome, yep. Get started. Hello, everybody, and yeah, please feel free to use the chat feature, jump in with questions anytime. Don't need to wait for any particular moment. I'll try to keep an eye on the chat. So welcome to our third installment of the Dementia 3D Echo series. Today's topic, evaluation and diagnosis in the primary care office or residential setting. So we're kind of building on our previous topics, so getting a little more into specifics about evaluation and diagnosis beyond screening and identification of cognitive decline, and why we do it in the first place, where we covered in our previous sessions. All right, just a little reminder about nursing continuing education credits. No new disclosures. And then any announcements from anyone we need to make now, besides the usual stuff?
This is my standard plea for cases. The whole point of this echo session is that we all share and we all learn together. And so we best learn through recognition of common cases and behaviors from our patients, because we're all struggling with some of the same issues. So please, we do request that you submit cases to us. You don't have to make it super complicated. If the form intimidates you, just give me a call, or we can talk through. You can send in a couple of paragraphs about what your main problem is. And this is an informal and very safe group. So I do encourage you to take a look around your facility or your clinic about the patients that kind of give you the most heartburn, or you're like this nagging sense that you could be doing something more. Submit that case. Dr. Gomez here. We're here to help. So we want to do that.
Absolutely.
Any other announcements?
All right, keep going, keep plugging away. The reminder of the schedule. Today, on November 10th, we're talking about evaluation diagnosis. Next up will be referral and specialty testing right during Thanksgiving week. Likely that will be a guest speaker speaking then, and we have a couple other guest speakers lined up, which I'm very excited about for future talks as well. So get a little bit of diversity in teachers here. All right, let's jump right into evaluation diagnosis in the primary care office or residential setting. So again, making this applicable to anyone in the outpatient or residential setting, as our attendees tend to represent both environments. What we want to focus on today is identifying the three basic symptoms of Alzheimer's disease that's separated from all other conditions that cause cognitive decline. Describe the workup for Alzheimer's disease, and really the workup will apply for, it'll be generalizable to underlying like neurodegeneration in general. So even beyond Alzheimer's disease, vascular dementia, Lewy body dementia, other common diseases of the brain that cause dementia. And then discuss the additional validated tools for use to further support the diagnosis of AD. So how do we become more confident in our diagnosis? Especially so as you're taking care of patients, outpatient, residential, and what kind of workup they've gone through, you can kind of get an idea of the confidence level of what their diagnosis is. So just to recap here, value of early diagnosis. So most common causes of dementia are Alzheimer's disease and vascular disease or vascular dementia. They do commonly go hand in hand, meaning you can have both. Unfortunately, you can't, just because you have one doesn't mean you can't have the other. Early diagnosis allows for retained abilities in determining the person's wishes, establishing advanced directives with preserved capacity. So it's really critical. That's why we want to start this process early. Also, research, large scale research, with thousands of patients, has really repeatedly shown now earlier diagnosis and characterization, and I'll keep repeating this, allows people to live independently and live at home, stay where they want to be for years longer. Most studies show 2+ years longer. That's a pretty big benefit. It's not just good for the patient, right, for them, because it's their autonomy, but think about the impact on the healthcare system as well by saving that time. Determine the cause may also help select the most appropriate medication, prevent further deterioration. Absolutely. Big issues, right? A lot of polypharmacy or incorrect use of medications in people with decline because of dementia will inadvertently or iatrogenically cause further decline. So what's the purpose of a medical assessment, right? We need to know, well, who is this person? Sometimes we're meeting someone for the very, very first time. They don't have really much records at all. If we're lucky, they have some previous records. We have some baseline, but we need to know what their baseline is. And the baseline means, where are they at day to day without, COVID, without being sick, with a good night's sleep. You're trying to take into consideration all these factors to know, like, where are they right now at their best? What's the relationship between their medical conditions and their functional impairment? So maybe they have Alzheimer's, but maybe they also have sleep apnea. It's really important to tease those apart because they're both going to impact their cognition. And so to that point is we want to identify the conditions that can be reversed or improved, because I would argue with you the vast majority, like 95+% of people with Alzheimer's disease have conditions that can be reversed or improved, meaning you can see improvement. So that's always the rule. It's so rare that I have someone that's so healthy otherwise, sleeps great, eats great, exercise, everything, and has Alzheimer's disease. And that's kind of our only focus. That's really the exception. Define coexisting conditions, plan and impairments in plan management. Determine capacities which remain preserved. Very important, right? To think about what kind of care they need, what kind of support they need. There is a variety of presentations with Alzheimer's and different types of dementia. And then evaluate their social, environmental, spiritual strengths and weaknesses. Now, this is just as important to do on the outpatient basis as it is in the residential setting, right? Supporting our patients wherever they are. Major neurocognitive disorder. So this was, kind of a relatively new term, but boy, dementia has gone through so many, terms over the years, from 100 years ago all the way to now. We've called it all kinds of stuff. But now this is sort of the newer formal diagnosis for dementia, just calling major neurocognitive disorder. And we talked about this in our previous sessions a little bit, right? It's an impact on the ability to be independent. And so are you getting lost? Are you burning stuff? Are you not able to cook? Are you forgetting your appointments, not paying your bills and so on? Once your independence is being threatened and to a degree that you do need help, that's where we're crossing into dementia, major neurocognitive disorder. And so American Psychiatric Association kind of introduced this term. This is pretty much what we widely use just to capture, again, dementia. It doesn't talk about biology, does not talk about underlying issue, just functional. And so specifically, Alzheimer's is a type of dementia, right? It's a type of major neurocognitive disorder. So if we're drilling down and we're going to say, okay, it's Alzheimer's disease, that's the biology that's driving the dementia. Well, what is Alzheimer's disease? It's a decline in memory or learning in one other cognitive area. So executive functioning, judgment, personality, mood, visual processing, language, and so on. So one other area plus memory, based on history or trials of neuropsychological testing. So with those tests we talked about last session, right? If we're seeing 2 or more areas, then and their functional decline is there, that can be Alzheimer's disease. It's got to be steady. It's usually a slow, steady decline. There can be some periods of stability. There can be some variation because often with what we said, right? Often with Alzheimer's disease, there are other co-occurring issues. So they can kind of muddy the waters a little bit. Like maybe there were 6 months of last year where they had untreated sleep apnea, and that's going to make them look like they kind of took a big drop and they jump back up. So there'll be some variability, but in general, when you look at the multi-year progression, it's this gradual decline. And really you've ruled out other major issues. They don't have a brain tumor, their sleep apnea has been treated, their anxiety and depression have been treated, and so on. There's still slow, steady decline. So what is the spectrum and kind of the percentages that make things up? So, vascular dementias or multi-infarct dementia. So there are people that have strokes and we know have strokes. Well, we know then that they have vascular disease in their brain. But most patients, we're not witnessing an observable stroke, but they have lots of vascular disease. So that's something we would see on an MRI. And when they lead to vascular dementia, that's about maybe 5+%, although I would argue it's more than that. There's a good 10%, a big chunk that's vascular dementia and Alzheimer's dementia, so that mixed, because again, it's common, especially as you get older, age being the biggest risk factor, right? We learned that before. You're going to have higher percentage chance of Alzheimer's disease, but also higher chance of vascular dementia, especially if you have longstanding diabetes or cholesterol issues, blood pressure issues. Alzheimer's, we call 64%. I think more recent research probably update this slide a little bit. I mean, I think this number is probably going down, and we're recognizing that other dementias are actually more common than we thought. Lewy body dementia, a big chunk of people. Dementia with Lewy bodies, Parkinson's dementia, also they're kind of overlapping a bit here, right? But Lewy bodies is just a different type of protein. These are all talking about different proteins. So Alzheimer's, amyloid tau proteins, Lewy bodies or alpha-synuclein, that's just a different protein that's causing the problem. Other dementias, there's prions like Creutzfeldt-Jakob, that's mad cow disease. That's a different type of protein, prion disease. So it's lots of different proteins. The point is, these different proteins like to go in the brain in different places and cause different types of dementias, Alzheimer's being the most common. So how do we work up Alzheimer's? That's kind of what we're here to talk about. So again, we talked in our previous session, history, clinical history is critical. That's where we want to spend most of our time. We want to establish a long-standing, slow, gradual decline, identify the functional areas they're having trouble with, identify the reversible causes. That's really going to start building this picture of, okay, I'm thinking about dementia, and I'm specifically thinking about Alzheimer's. Not a lot of curveballs in there. It's a kind of a classic Alzheimer's. They've got some slow memory loss. They've maybe got some depression, some sleep issues, but they're not having hallucinations. They're not acting out in their dreams. They're not having lots of fluctuating throughout the day. They're not delirious, thinking about Alzheimer's. So we're just touching on delirium, right? Ruling out common issues that can mimic memory loss or Alzheimer's, anemia, thyroid disease. Going through their medications, that's a big part of what I do, right, is taking away a lot of medications that can cause memory issues. All those anticholinergics, for example, we use for bladder control or stomach upset or allergies or things, all those Benadryls out there, not good once you're starting having cognitive decline. Ruling out treating depression, very commonly overlapping with dementia. We'll do diagnostic testing beyond screening, and we'll get into that. And specifically, biomarkers that we use, and I want to talk more about that. So we do the neuropsych testing, but we'll look at brain structure imaging, like a head CT or a brain MRI is even better. But then we can actually get even more specific. We can look at spinal fluid for amyloid and tau protein. That's pretty definitive. We can also, there's amyloid and tau imaging of the brain, although that is available. It's not, Medicare is not yet like a wide scale approved it. They're supposed to, they've indicated that they will, but it's still not widely available. So that'll be another thing where instead of getting the spinal tap, which a lot of patients don't want to do to get that amyloid tau, you can think about doing the imaging of the brain, although the spinal tap is still a bit more definitive than the imaging. ApoE protein, not super exciting. We touched on it the first session, is that ApoE, a lot of like the 23andMe's, I like to give you your genetic result. This is one of the proteins, that's important for cholesterol. So some people have a variant of it, and if you have both variants of it, which is uncommon in the population, but if you do, your risk of Alzheimer's goes up by about 6 to 8%. So it's not a huge percent increase. It pales in comparison to other things, but that's something you can test for. It's something definitive we can find out. So when we're talking about diagnostic testing, we're moving from screening, which is, okay, something seems to be going on. Diagnosis is then going to hit the underlying biology. It's going to tell us what's going on. Is it Alzheimer's? Is it Lewy body dementia? Is it something else? Meaning it has to be accurate in telling us the answer we need. The Alzheimer's disease includes a clinically valid history and a variety of biomarkers. So again, tau and amyloid being the main proteins in Alzheimer's, we have all these different ways of measuring them. And so we used to do autopsies a lot because we would kind of figure out, were we accurate? Like, I thought this person had Alzheimer's disease. Well, in the early 2000s, we had some big studies that followed people to autopsy. And believe it or not, in many cases, 50% or less of the patients with Alzheimer's actually had Alzheimer's. So we basically, historically, we've been as good as a coin flip in terms of diagnosing people accurately, which is pretty amazing, right? Turned out a lot of those people had Lewy body stuff. They had TDP43 protein. They had all kinds of other proteins causing issues. We were off. We've gotten better at it since then because now we have all this testing that's come out, which I'll talk about. But our kind of traditional diagnosis was really inaccurate. And then there's this National Institute of Aging Alzheimer's Disease Research Centers, and disease associations that have these criteria for possible and probable. We'll talk a little bit about that, but those just incorporate the testing, meaning I think this guy has Alzheimer's. Well, I then did a spinal tap. It told me, so now it's probable. Now I'm pretty sure. This is a slide I added that I like to kind of point out. I think it's really helpful to look at this. The purple line, so on the x-axis, right, we have how far along in the disease are you? We've got pre-symptomatic, we got early mild cognitive impairment, late mild cognitive impairment, then dementia. So as I'm getting older and it's getting worse, I'm going to dementia. And then everything down here is normal. When are these biomarkers detecting something is wrong, meaning going to abnormal? So now this purple line is clinical function. So through most of history, right, we have to rely on clinical function, meaning until the person was leaving late MCI, mild cognitive impairment, entering dementia, missing their bill payments, forgetting things, getting lost, all that. That's when I was picking them up. That's when it started seeing abnormal, right, stuff. So this is our baseline kind of historically. Now we have the benefit of a few more things. Now we can do those screening tests like the MOCA, the SLUMS, the MMSE, neuropsychological testing. That will pick things up later, or earlier, I should say. So mild cognitive impairment will pick that up. So that's cognition. So testing their cognition starts to decline before your functional decline, right? Like you might start having some issues remembering a list of 10 words, but you're still living independently. But at some point, you'll start to have trouble living independently. So that's the point here. Then we step back a little further, MRI brain structure. That goes even further, a few years before. So that's why I get brain MRIs on all my patients, because it can help me nail things down and detect things even earlier. And what's interesting is look how much earlier we can go. The spinal fluid, we can go back into pre-symptomatic stages, meaning we can technically diagnose someone with Alzheimer's before they have any symptom or decline whatsoever. So traditionally, let's say someone's 80 years old, this could be as far back as age 60, 65. So we're talking years, because this is a very slow buildup. And then even further, FDG PET. So this is a special glucose PET. We use this in cancer a lot, so some of you may know FDG PET. Microglial activation, so this is stuff that happens at the brain cell level. PET amyloid beta, that's the amyloid beta scan I just talked about. The Medicare's indicated this is the IDEAS trial, that there's a second one going on now to add more evidence to support this. But look how far back this goes. I mean, this is so many years before you actually have decline. And then it's the amyloid beta 42 test. And then this is for amyloid beta 42 rather than for tau or p-tau. And then astrocyte dysfunction. So again, we're talking about the very first thing that's going down that we think in the kind of cascade is your astrocytes in your brain start dysfunctioning. Well, there's this whole cascade effect that takes decades to then make you demented. But we do actually have all these tools that go really far back. And so part of what we're doing, right, is adding this to the toolkit for us as providers. And there are a number of places around Montana and the states, Alaska, Hawaii, Wyoming. There are hospitals that can do these tests, like CSF tau or amyloid beta. That's a mail out. It's a very easy mail out. So anywhere that does a spinal tap can do that. So any doctor that does a spinal tap can mail that out. The PET scans and the specialized imaging, most places have access to an MRI or head CT, but the FDG PET, anywhere with nuclear imaging with a SPECT scanner can do that as well. So I luckily not had a lot of issues helping patients find places. Sometimes they have to drive a couple hours, but that generally is available. So don't get overwhelmed with this slide. I just want to really point out some of the inherent challenges with diagnosing specific Alzheimer's is that the syndrome of Alzheimer's, meaning syndrome, we mean memory decline, the clinical kind of picture does not necessarily equal Alzheimer's disease, right? So not everybody with slow memory decline is Alzheimer's, right? There's other things. So Alzheimer's disease, amyloid beta, proteins, there's something called hippocampal sclerosis. There's something called argyrophilic brain disease. Again, these are just different diseases in the brain at the actual microscopic level. They all lead to the syndrome of memory loss, short-term memory loss. And the same thing is Alzheimer's also leads to different syndromes. Most people with Alzheimer's sure have amnestic memory loss, but some of them have visual issues first because the back of the brain gets affected. It just depends on where does the amyloid beta protein or tau protein decide to go? Where does it decide to hurt first? Well, it's hurting their occipital lobe, the back of their brain. That's going to cause visual symptoms. Oh, it's causing damage in the temporal lobe or the parietal lobe on the sides, that kind of behind the ears, that's causing language issues first. So you see, it can become a little challenging because Alzheimer's can present in different ways, and a bunch of different diseases lead to memory loss. So just keep that in mind. It's a very important consideration. That's why it's not so easy. And then my soapbox here, which my colleagues at Mass General and Boston and UMass, where I trained previously years ago, really support is, let's try to have every patient we work with, whether outpatient or the nursing home, to kind of have documented this 4-tier diagnostic formulation, meaning what's their clinical syndrome? Okay, well, they have short-term memory loss. Nope, you know what? They're having language issues. Actually, they're having visual issues, whatever it is. So you're capturing, this is like an amnestic, let's say. What's the stage? Well, it's subjective, meaning the patient thinks they have an issue, but I can't actually find an issue. It's mild cognitive impairment. I'm able to actually see an issue on the MoCA or on neuropsych testing, but they're living independently, or it's dementia. They're no longer fully independent. So they have amnestic, memory loss. They're in the dementia stage, so they're demented, major neurocognitive disorder. And I think it's because of Alzheimer's disease, beta amyloid and tau. And then, what are the additional factors is the fourth thing. So they also have untreated sleep apnea, depression. If we have that in the chart of every patient as best as we can, I mean, think about how much more information we have and how much more ability we have to treat those patients and really help them. I mean, this would drastically change the landscape of memory loss and memory treatment in the US or in the world, really. So that's my big soapbox is we can all contribute to this. We can all talk about additional factors, the depression or sleep apnea or the anxiety. We're all capable of commenting on stage, and we're also all capable of commenting on the syndrome. What's the pattern of issues? Are they having, are they like more Parkinsonian? They're having more motor issues. Are they more socially having issues? They lost their empathy and they're being inappropriate. Are they just losing their memory? Those are all things we can comment on. And then we can really rely on our providers and give them the direction, because if we build that picture for them, it's a lot easier than go down the pathway of, well, what's the biology? Because this opens the door to treatment and being very specific about future treatments. Again, the biomarkers, because we're getting more and more of these. We're going to see this spreading a lot. I use these routinely now. And the point is, like, what do they help with? That slide is to explain, well, what do they help with? So we talked about that special sugar PET scan that we use in cancer a lot. Well, it helps us know, is there something neurodegenerative or not going on? Meaning, if I look down this PET scan, normal PET scan, right? My brain should be lighting up like Christmas lights, right? It should be eating up all the sugar and using everything. That's what it's all nice. And the red is like a very strong signal. If I'm depressed, it should still all be lit up. If I have sleep apnea, it should still all be lit up. Do you see what I'm saying? So all those issues that can cause mimicking dementia should not be keeping your brain cells from eating sugar. The things that keep your brain cells from eating sugar are the things that are killing your brain cells very actively. And those are things like dementia. That's why it can help me figure out, is it degenerative or not? Alzheimer's, look at that. It wipes out these kind of medial parietal lobes or the parietal lobes. So kind of right at the crown of your head going down. That's a home run. That's dementia and is very likely Alzheimer's. Frontotemporal, look at that front part of the brain, just completely quiet. It's gone cold. So it's a very helpful scan to help differentiate Alzheimer's from frontotemporal dementia or degenerative versus non-degenerative, okay? But remember, it's not telling me what protein is doing it. It's just telling me, but it is still very helpful. PET scan, perfusion PET or SPECT, similar. I always just go with FDG PET. I think it's a better scan. Dopamine transporter imaging. So this is this one. This is very classic to help me figure out, is it Parkinson's or not? A lot of people have weird side effects from antipsychotics or strokes and things like that. And I use this to figure out, well, is it drug-induced Parkinson's? Is it, vascular Parkinson's? Is it something else? Or is it, is it Parkinson's disease? So this is normal. This is deep in the brain, sort of very deep. If we go kind of the lower part of your ears and all the way to the center, right at the top of your spinal cord, you have this caudate, you have these basal ganglia, you have caudate and putamen. They're eating up the sugar nicely. It looks like a comma, kind of, think of it that way. Look at this, all that's left we call period sign. It's just a couple periods left. That means this is pretty much a home run for Parkinson's disease. So again, very helpful because it's giving me a very clear answer. We used to do this much more routinely, but Parkinson's is actually, for most patients, reliably diagnosed clinically. So I don't use this very often, but it is when those patients have a lot of vascular issues, strokes, or have been on a bunch of antipsychotics, can be hard to tell. Amyloid beta tau in the spinal fluid. Again, anywhere that does a spinal tap, we can mail this out. Mail it to Mayo Clinic, or Massachusetts has another lab that does it. Athena Diagnostics in Massachusetts and Mayo Clinic, I think, are the only two labs nationally that do this right now. I may be out of date. But you get them back within a couple weeks. And this tells you, is it Alzheimer's or not? So this is very helpful because that's going to actually measure the proteins, unlike those scans, right? And then amyloid PET is also going to measure the protein, but through imaging. So I hope this makes sense. Some of these are going to tell me, is it dementia or not? Is my brain just not working? The pattern of not working can be helpful to know what kind of disease. But then there are more now where we're actually going to measure the actual proteins in there and know which dementia. And really just pointing out, again, I don't use, the vast majority of my patients, I diagnose and I do all of that without those fancy tests, maybe just the brain MRI. A smaller subset, I might go down the road of like a FDG PET, a glucose PET, less invasive, still good information. And then a smaller proportion, I'm sending for spinal tap or more specialty testing, but it's not common. So, and the reason I would use these specialty tests, right? There's persistent or progressive unexplained MCI, meaning I don't have a good explanation for it. Maybe they're younger, something's not fitting. They have a possible Alzheimer's disease diagnosis, but maybe there's something atypical about it. They're not one of the common short-term memory loss people. Maybe they're having visual issues. Maybe they're having language issues. Maybe they also have other stuff. And it's progressive. It might be earlier than age 65, which is atypical. And so if they're kind of fitting, something's not quite right, something's atypical, and that information is going to help the patient because if it's early onset, it's going to affect their family. A lot of the family want to know. It's going to affect their future life planning, treatment planning, and so on. Treatment, even though we have limited treatment is different for Lewy body dementia versus Alzheimer's versus vascular versus frontotemporal. So it is important. We do objectively do things differently. So if you can answer that question, if it's going to help and it's going to change the care of them, then it's appropriate to do it. We don't want to that's why we don't use these as screening, right? We're not going to go out and just do tests on everybody. With the brain MRI, I just wanted to point out, I love brain imaging. I pull up brain imaging all the time. These are examples of brain imaging I look at. MRI combined with clinical history, the majority of the time gives me my answer because we're getting better about the patterns that we didn't know about before. So for example, on the left here, this structure that's in the circle, that's your hippocampus. You might have heard of hippocampus on both sides. Here's your hippocampus. This is, again, your ear is kind of like out here. So this is sort of deep to your ear. Here's the top of your brainstem and your basal ganglia. So your spinal cord's coming up. I'm looking straight on, looking front to back. So this person's looking straight at me. And here's the hippocampus, the structure, right? And nestled in here. A little bit of space opening up, but overall, this is normal. This is probably normal for like a 70, 80-year-old. So this is a nice big structure. Now, if I look over here, check this out. Severe atrophy. Look at that hippocampus. It's all atrophy down. If I see this on a brain MRI, this is a home run for dementia. I mean, this is someone has a neurodegenerative cause for dementia. There's no other reason your hippocampus is this small. Something is very wrong. And this person very likely has very obvious memory issues. Now, keep in mind, you'll be surprised sometimes the disease you'll see before you see functional changes because education level, remember, and all those other protective factors in your life will make a big difference. So let's say if this patient didn't finish, let's say middle school, this person, I would guess, is living very debilitated in a residential setting and need help with everything. If this was, super educated, a college professor and worked their whole life using the brain, this person might still be living at home with some basic care. That's the range you'll see with what you'll see in the brain, isn't it? It's amazing. So the education is very protective. It kind of you can kind of take a lot of damage before you start showing it day to day. Here's the medial parietal lobe. So right under the crown of your head, towards the middle of your brain, we're looking sideways now, just pointing out. In general, you can see like the brain looks pretty uniform. The wrinkles are all similar. Then boom, you look here, look how atrophy that is. Look how much that's shrunken down. That's also classic for Alzheimer's. Alzheimer's loves to go to the hippocampus, medial temporal lobe, and to the medial parietal lobe, or the precuneus, we call it. So I just want to point that out because, for me, it's very interesting looking at brain imaging and it offers so much information. There's just a couple examples. Now, that glucose scan I told you about, a specialized glucose scan, we kind of saw a little bit earlier. Again, normal, sugar being eaten up all over your brain. Alzheimer's, that medial parietal lobe right under the crown of your head, dark, both patches there. That's a different view. This is looking from underneath. This is looking from the side. Same idea, right? These are real patients. Now, another thing to keep in mind as we're diagnosing is, right, the rule, not the exception, is tons of behavioral symptoms in Alzheimer's disease, right? This is the rule. And so months before diagnosis over left, and then the dotted line, and then months after diagnosis, and what percentage of patients have these. So, if I'm like, let's say a couple of years before diagnosis, generally, suicidal ideation is lower, paranoia, things like that. You might start having a lot of social withdrawal though, because what happens to people if we think about it? People will start noticing, they might internally notice something's wrong. They might think, hey, I'm having some trouble, get self-conscious, right, with their memory or their ability to talk with their friends. So people will start socially withdrawing, a while before they get diagnosed. So that's often an early sign of depression, that kind of stuff. Their sleep cycle will kind of get screwed up. And then as we go after diagnosis, man, very common, right? 80% of patients, unfortunately, will have some episodes of agitation. Now, remember that agitation, there's almost always a good reason for it. Like, I'm losing my memory and someone's coming in my house and trying to, help me put my pants on. Well, if I have a bad memory, that can be pretty agitating, right? Because like, who's this person? Why are they taking my pants off or whatever it is? So you got to keep in mind, I mean, we call it agitation, but it's contextual. It's often explainable, but it's a challenge you got to deal with. Aggression, wandering, hallucinations, that kind of stuff. So you can kind of see the spread here. Any questions so far? Amber, you asked, sorry, I missed that. Is there any increase of dementia related to drug and alcohol use now that we are seeing wider adoption of legalization? Dementia related to drug. So absolutely. So I mean, so specifically alcohol related dementia is definitely a long-standing issue. There's something called Wernicke-Korsakoff syndrome. I just saw a case recently. So people that do long-term use substances, especially alcohol, we know that for sure, will absolutely be a high risk for dementia. It's an interesting pattern. I mean, Wernicke-Korsakoff, you can have cerebellar atrophy, which is why they can permanently have issues with walking and coordination. Your mammillary bodies get atrophied. So there's kind of some unique stuff that happens, but that's absolute risk. And then chronic use of stimulants, for example, can cause vascular disease in your brain, lead to vascular dementia. So there definitely are links. With the wider use of cannabis, it'll remain to be seen. No direct links right now to dementia, but cannabis doesn't work as aggressively, for example, in the vascular system the way alcohol and stimulants do. So I suspect that's kind of a reason for it. So let's say you did the MOCA, you did the slums, you did the mini cog, you did something in your clinic or at the nursing home, at the facility, the assisted living, where something was off. Well, you can do the longer version of MOCA as a longer version. The point is you can kind of do this sort of 10, 12-minute version. I work for a company that does computerized cognitive testing. So there's a lot of computerized examples now. That's growing in popularity. So you could do one of the computer-based tests because oftentimes it's just easier and takes less time. You should be capturing their functioning level. There's lots of these. I mean, these are just examples, right? But there's lots of questionnaires that capture function. Critical to have someone who knows the patient well, a caregiver, a loved one, or a staff member that's maybe worked with them to fill that out as well, because that's critical. We need a questionnaire or testing from the patient, their cognitive testing, their own impression of what's going on, but we need the impression absolutely of a third party. That's a must. We can't do without it. I think I told you guys stories before where people will insist coming into clinic or even living residentially. Oh, I don't have anybody. I've always been able to find somebody. It might be their librarian, it might be their mail person. I mean, just someone that has had some kind of exposure. So those are just some examples. Again, checking for depression. So you want to throw out some tools at them, get caregiver information, get patient information, get their symptoms. And then we want to part of the diagnosis then with those, so again, with all the workup we've done now, the clinical picture, we've described the symptoms, we've described the severity, the syndrome, and we're trying to think about what are the most common causes of dementia and what are the underlying biologies. Well, here's some of the differences that help us differentiate just based on clinical picture. So course of the disease, Alzheimer's being gradual, dementia with Lewy bodies is fluctuating. People have kind of their ups and downs. These tend to be people that end up in facilities sooner. It's harder to live with. Parkinson's disease tends to be gradual. Keep in mind what's kind of confusing is the protein that causes both of these is the same. It's just Parkinson's affecting your motor centers, those core basal ganglia. Dementia with Lewy bodies affecting more your memory and your cortex first, the outer brain. So dementia is the initial presentation of Alzheimer's. Dementia with Lewy body, you might have some Parkinsonism first, but you got to have the dementia first too. And then Parkinson's is extrapyramidal. This is getting kind of fancy, but what it means is outside the pyramid is a specific part of your brain and your spinal column. And so it's outside of those cells, meaning you're having movement issues first. Cognitive symptoms onset, progressive cognitive decline from disease onset. So everyone's going to have this progressive cognitive decline with Alzheimer's. Again, Lewy body, you want to see that dementia first, then the motor symptoms. That's why we call it Lewy body versus Parkinson's, the motor symptoms need to start first. If you live long enough, and we always say, if you live to 120, if you live long enough, you're pretty much everyone, at that point gets Parkinson's, but you'll get dementia, but not everyone with Parkinson's ends up by the end of their life having dementia. It just depends on how long you live. So it's not always. Psychosis, delusions with Alzheimer's, right? People get paranoid. That's more the common issue. You don't usually have hallucinations with Alzheimer's unless you're delirious, right? So if someone with Alzheimer's in a facility or an outpatient starts hearing or seeing things, that's a trigger for me to check their UA, to check for medical reasons. Now, if they're having visual hallucinations and they're not sick, that's much more common in Lewy body dementia because the Lewy bodies like to go to the visual cortex in the back of our brain and mess with our eyesight processing. And then Parkinson's tends to have medication-induced visual hallucinations more common because what do we do with Parkinson's? We give them dopamine to replace the cells that are losing the dopamine. And what does dopamine do? It causes psychosis. What do antipsychotics do? What does Zyprexa and Haldol and Seroquel, all those do? They block dopamine. So we get in this tug of war, right? Trying to help your mobility. I'm giving you dopamine. It's causing psychosis. Then I'm going to give you an antipsychotic to block the dopamine, and we get this tug of war. This is a super common, very challenging situation for people with Parkinson's disease, psychosis, and dementia. Motor symptoms. Alzheimer's, again, you can have motor symptoms in all of these things. So you can have gait issues, rigidity in later stages. So you can start to mimic it a little bit. It can mimic Parkinson's. Lewy body dementia, you will get some slow movements, bradykinesia, rigidity, stiffness, trouble with walking, usually more shuffling gait, shaking, tremor. But again, dementia first. Parkinson's is where you get your resting tremor. Sometimes we call it the pill rolling tremor. Rigidity, meaning it's really stiff. Like you try to bend their arms or their knees or their wrists, and it's just really stiff, but they're not fighting you. It just feels like it's tight. They can't kind of, instead of doing a normal finger tap, it's kind of out of coordination and slow. And then that kind of, they start to lose their balance. They start to fall over a lot easier, have shuffling gait, stooped posture, lots of stuff with Parkinson's, masked face, stuff like that. So we can figure out, this helps us even without getting to any kind of real formal testing based on clinical exam, we can figure out really well what's going on underneath. Now, if we have the benefit of knowing the biology, okay, Alzheimer's really having a lot of beta amyloid plaques, tau tangles, dementia Lewy bodies, right? Lewy bodies are alpha-synuclein. That's the main protein in both of these. It's just where is it, right? Cortical versus brainstem, what we mentioned earlier. And then hypersensitivity to antipsychotics. So again, this is one of the reasons we need to know because someone has Lewy body dementia. So Alzheimer's, I might give them risperidone to help them with their psychosis and agitation. I do that to someone with dementia with Lewy bodies or Parkinson's, not going to go well. They're going to get extremely stiff, right? Because what do we say? That's going to block dopamine aggressively, and that's exactly what they need. And so they're going to get really stiff. It can make things a lot worse. It can be pretty dangerous for them. So yeah, these are all important things to know before we treat. Any questions? We covered a lot of material. Ask some questions because we talked about, right, the severity, the syndrome describing the clinical course, then all the way to the biology, and also reversible factors, and how we do that outpatient setting, clinic versus in a residential setting. But does everyone here feel like they have a better handle on what causes Alzheimer's, different types of dementia, and how to take a step towards having a more comprehensive description in the chart or diagnosis?
Anybody in particular want to talk about perhaps some changes that they've seen in their practice when they're trying to improve the care of these folks to get a better, more accurate diagnosis? Has anybody implemented anything that is, super helpful? We have a question from Mariana.
Yeah, does Parkinson's need to be diagnosed before dementia? So in the case of Parkinson's, if you have Parkinson's disease, you have motor symptoms usually years before dementia. So yeah, you're starting to have that stooped posture, shuffling gait, the finger tapping breaks down, stiffness. You might have a resting tremor, those kinds of things. Those are all pretty equally distributed, by the way. People always look for resting. Like what I'm doing right now is not a resting tremor, keep in mind, because I'm holding my arm up. Resting tremor means my muscles are completely relaxed. So I'm sitting, my muscles are not activated, and then my fingers are moving, I have a tremor. Anything I'm doing right now, my arms in the air, is action tremor because I'm using my muscles to do it. Does that make sense? And only about a third of people with Parkinson's have a resting tremor. So keep that in mind. The tremor is actually not the most common thing. But yeah, hope that answers your question, Rihanna.
One of my take-home kind of ideas was that, really after you do the basic screening pieces, that if you have any sense of protocols or prompts within your EHR, it sure seems to me like the next step is brain imaging. And I'm just curious how commonplace that kind of protocoled approach to after the initial dementia kind of screening types of questions is actually implemented in general practice.
Yeah,
and then Simi actually asks if Medicare pays for it, because we all know things don't get done unless they're paid for. So both those kind of tag team.
Yeah, absolutely. So yeah. So, first part of the question, widely people do get head CTs and brain MRIs, and that's usually where it kind of stops. So like if you see general neurology or primary care or whatever it might be, you usually get to the point of structural brain imaging. The challenge there is what I showed you back here, for example, like that actually is not going to be commented on by radiology. So I have to read all my own brain imaging. That's slowly changing right now, but nationally, when you get the radiology report back, it's going to say, oh yeah, normal brain, a little bit of atrophy, and no strokes or tumors and things like that. They'll usually totally swing and miss on a very obvious Alzheimer's disease, because it's just not part of like the standard report and standard training. So these are all things I have to comment on myself. Like I've never seen a radiology report, a radiologist say, oh yeah, they have hippocampal sclerosis or atrophy, or they have medial parietal lobe atrophy. There are more softwares out there like Neurocognitive that are automating it for them, that does kind of bring it to light. But again, so keep that in mind. Even if they've had a brain MRI from a few years ago or recently, I have to read it myself. I don't actually really even look at the radiology report. I mean, I do, but it's not, the ultimate thing I need to look at. So just again, so even if they've had that brain imaging, usually it requires another look over. Now, the more specialty scans. So luckily Medicare, CMS does pay for FDG PET scan if you're documenting, is this to differentiate Alzheimer's versus frontotemporal dementia, or, neurodegenerative versus not. So you can't just like kind of do it willy-nilly. But as long as you document that, it is paid for. I do that routinely, and vast majority of my patients, vast majority are Medicare, Medicaid. And then same with spinal tap. You can send someone to your local hospital, get the spinal tap, mail it to Athena, or Mayo Clinic, I think is even a bit cheaper. But yeah, that's covered by insurance as well. And so those are the two main ones that you might ultimately do just to be more definitive.
One other question that I had, I thought that some of those tables that you had about the various types of symptoms, right there, yes, that one. You know, I was wondering just from the group if this little table would be helpful to post in your clinic or in your nursing home to kind of remind people about how that's differentiated. If that isn't helpful, we don't need to do it. But that is something that Mountain Pacific could assist with, you know, creating some, you know, kind of handouts that you would have around your facility. So if you're interested in that, I think most of you have my email. You can just send me a note. I'll stick my email in here.
Other questions? So from today, if all of us can go out and next time you see a patient and you're thinking, okay, they have memory loss in their records, or we kind of know there's something going on, try to document the type of memory loss or cognitive changes you see, just get a little more specific, the severity, how much is impacting their function. Are they mild cognitive impaired? Are they demented? You know, think about those reversible factors. Is there sleep addressed or anxiety and depression addressed? That right there is hugely beneficial to that patient and to the healthcare system. So that I think is a really big step I would love to help, you know, support everybody to take. And then you don't even have to worry about the underlying disease at that point. You know, that can be for later, but we don't have to nail down Alzheimer's right away. But even going that far would be a big step forward.
This is Alana, and just wondering, I know, I think that's a really good idea, Amber, to be able to offer that tool out. Is there also any other type of tools that helps just in terms of like whether it's a deducing, you know, symptoms and then going from there, or some sort of algorithm that would help, you know, if they're seeing, you know, the forgetfulness, or if visual disturbances, you know, possible tests, possible, you know, rule out this type of tools or resources?
That's a good question. Some of the screening tools, so like MoCA has some, you know, visual stuff on their language stuff. So I mean, it's a kind of screening tools, or the testing. Neuropsychologists will drill down where they find an issue, so they'll do all kinds of tests. So there are tests. They're always like, they tend to be creative, like matching words and colors, or coming up with the right word meaning, testing language centers. So those are the kinds of ways you'll get into it. Some of the screening tools touch on it, and then, you know, by the time they make it to me, I'm drilling down more to figure out where are the impairments and characterizing them specifically. Is that a little what you're kind of asking?
Yeah, I think so. I guess without seeing them, I wish you could just see inside my brain right now. But
well, like with MoCA, I'll point out, like with the MoCA test, you know, the classic Alzheimer's pattern on there is like the short-term memory part where you have to remember those 5 words later. That's low. And maybe the trails be that 1A, 2B, 3C, that might be impaired. That's sort of like classic Alzheimer's. The rest of it, like calculation abilities, verbal abilities, is pretty much okay. So then you can start looking at it a little bit more nuanced and say, oh, this is pushing me towards also not just cognitive impairment. Yep, clearly their score is low, but I'm also thinking this is Alzheimer's pattern. Or their memory's a little more intact, the trails, but visually they're having more trouble. Their clock drawing is screwed up. They might have, we call executive executive dysfunction, mild cognitive impairment. So, or their language is messed up. So we have, you know, language aphasic. So even from that point, you can start to kind of get some clues. I often see those clues that play out later and say, oh yeah, this was actually a language variant type of dementia instead of just Alzheimer's.
Yeah, I think that would be helpful. I'll have to look into that. I also, you know, that the point of tests that Medicare or other insurance would pay for, I think too, would be helpful, I think, for providers, especially I'm thinking specifically in our rural communities that providers are, yeah.
Right. Any other questions? Any other announcements?
once again, a plea for cases. That's how we learn best. So feel free to submit your problem patients to us. I think we might be able to give you some assistance.
Okay, well, thank you, everybody. Great to see everyone.
Okay. We'll go ahead and close out, and we'll see you next week. Thanks.